I would really like to sincerely thank the organizers and Dr. Manal for giving me the honor to participate in this conference. Over the next 40 minutes, I will be talking about behavioral issues in Down syndrome. And actually, my slide doesn't have, my talk doesn't have a lot of fancy charts or fancy tables or state-of-the-art statistics, but what it does have a lot of pictures. It has a lot of clinical experience that I have gained over the years from the parents that I had the honor to look after their children. And if they always put me on a learning curve, you never stop learning from this family. You can get all your experience from books, but what you get in real life is something genuine, and it is really helps all through, and it does clinically. That doesn't mean that I don't have any references. All the slides are referenced, but they are just as enriched by the families that I have been looking after. So the stereotype of children, that of all children, I'm sure we'll all agree that they are cheerful and friendly, and their demeanor give a very specific personality stereotype. But yes, this is the idea, but there are the children, about 20 to 40% do have significant behavioral problems. Even when we're talking children that they are sociable, sometimes the social, if they are overused or inappropriate, then they can come as a disadvantage to these children. For example, if they actually, and some of our residents that are sitting here will agree with me, in the exams, like the children, you get almost always we have children with Down syndrome in the exams for the students, and you tell them you are in control, careful that the child will be in control. And then what happens usually, the child will come in very sociable, talking to you, irresistible, you cannot avoid. 7 minutes is gone, you haven't done the test. And this is sometimes can be an escape strategy. And again, in the clinic setting, if the child, I'm talking to the mother, and then you find that the whole session has gone, the child is approaching you irresistibly, you cannot not but acknowledge the child. So when you acknowledge the child, that's it, the session gone. So we look at each other when we say bye-bye because there is another patient, gone. The whole session is gone without addressing the concerns. So we must be careful. And something else, the cute and charming behaviors of the children, we should not, like if the child, we should not most of the time encourage. Like if the children, you're doing these things, blowing raspberries, or making cute comments, or maybe when they are younger, like spitting or swearing, these things that we think that they are cute or charming, we should not be encouraged. So I would like to start, I come to my objectives, but I have few starting points which I will go through. First, it's a child with Down syndrome. As we have been all having, this is the theme, and in the pictures all around us. We don't judge the children. Each child is unique. We've seen hundreds of children. I'm sure everybody will agree there are areas of strength and areas of weakness for children. If I'm talking developmentally, I would know, I've got to study the child. As a doctor, I've got to know about Down syndrome. As parent, when the family has got a child with Down syndrome, they should know more about Down syndrome. So, developmentally, I know very well that these children have got better receptive skills than expressive. Their motor skills are weaker. Their nonverbal social interactions are better. Some of aspects of the visual processing is very strong, much better as a profile for the children. So when the parents, they know their child, they are going to give them this opportunity. I don't know, we have 20 to 40 genes. You've got mild intellectual disability, as we said yesterday, no mental retardation. This is obsolete now. We are calling it intellectual disability. So the children, I need to give these children the opportunity. If I don't give them these opportunities, as the parents or as doctors that should support, or professionals anywhere, it's a teamwork. Nobody does the job on their own. Then the child will have potential that will remain treasures in a closed book that nobody has ever explored. So you have got many children that are much more than capable, providing that they have been given the opportunity. Secondly, we are going to analyze the behavior and not the child. Not every single thing the child does is because Down syndrome. We really need to be careful. A child is like any child, so they've got to have the right discipline when right, but I've got to be aware. that what I am, on what basis, what is my baseline, what I know about Down syndrome before judging. So this picture, when I'm saying analyze, yes, everybody will agree that this child is being stubborn. But even though, if you're 100% clear that this child is just playing up, we still should analyze the behavior and not analyze the child. I put this slide there just to show developmentally what is the range that we can get for children. As you can see, this is then the Down syndrome children, and this is the typically developing children. The white part of the diamond is the average range, and the strength is so you can see the range. Children, no child with Down syndrome is the same. A child with Down syndrome, one child can be trained at 2 years, and one child can be trained at 10 years. And all this are within the scope of Down syndrome. The same applies. I mean, motor skills are one of the skills that are quite delayed, are significant areas of weakness in children with Down syndrome. Now, third, as has been said repeatedly, rule out medical condition. All the lectures that have been today and yesterday, they impact negatively on the children and the behavior. If I am dealing with the behavior, I must sort out the medical condition. If I don't sort out the medical condition, I will not be successful in managing the behavior. So when we are, this is whatever we're using, the UK or the American Academy, whatever school you are following, you must comply with this. And when I'm talking about screening, that means that children are normal. There is nothing, well, the children coming to your clinic, they don't have symptoms. You ask the history, you ask the right appropriate questions, and then to discover. And this is the surveillance and the screening. If the child is coming with symptoms, you are assessing him. So really, and sometimes when the children comes, say, was the hearing checked? Oh yes, he's been discharged. No, you don't discharge. Don't accept that. Go back again. So you refer back to audiology, refer back to ophthalmology as per the guidelines. Do not accept. They must have at all points of time. Hearing must be normal, vision must be normal. The child, any sort of pain, even the dental, the headache, the constipation, I will not be able, and that's why I'm emphasizing, we can do something about the medical before addressing the behavior. Behavior is very expensive sometimes and very demanding to pursue its management. Medical is much easier and feasible. You can catch it. And above all, unconditional love. These children, they feel. So when parents they really are genuine. We must teach them how to cope. When the parents, sometimes I get to the clinic and then maybe a mother is crying, and then she will say the child will look at her. And she says, oh, no, it's okay. I said, no, don't tell. I say, can you go and give mommy a kiss? Go and give mommy a hug. And when the child goes and gives his mommy a kiss, gives his mommy a hug, that makes a lot of difference. So we are teaching him. We are teaching the child how to, when he doesn't have this skill innate, we are teaching the child how to react in such situation. So these are non-verbal gestures. It doesn't need talking. So my objectives, after this long introduction, I'm sorry, I'm going to state the behavior challenges typical in persons with Down syndrome across the lifespan. And as we are aware now that there is longevity of the children, so we're letting a lot of adolescents and adults getting into with Down syndrome. And in UK, when I worked, we used to transition from the pediatric to the adolescent to the adult service at around 16. So 3 years from 16 to 19 before we hand over. In UAE, where I worked before, we are seeing children till 13. So I didn't have the privilege to work with adolescents in UAE. I will make a quick outline to the approach to the behavior issues. I will address dual diagnosis and state the major mental health concerns. So children with Down syndrome, compared with other group of the children with disabilities, they are at a lower risk of significant psychopathology. On average score, they score significantly lower on standardized rating scales of maladaptive behavior. I will define maladaptive behavior. And they show lower rates of significant behavioral or emotional problems. However, when you compare them to typically developing children, they show more problems in the young age group, and emphasizing in the younger, externalizing stubbornness and oppositionality on the same wavelength, inattention, difficulty concentration, attention seeking, impulsivity, and aggressiveness. The aggressiveness in children with Down syndrome It is the low level, it is provocative aggressive. They never engage in high or like fighting or high level of aggression. And it peaks the aggression at age 10 to 13 years, and then it decreases. So by the time the children are adolescents, there is no this aggressiveness as developing typically. Again, the aggressiveness is not malicious or mean-spirited. It is rather attention-seeking, or just to get the attention. They are not mean-spirited. It is, you don't feel it, they are evil with it at all. So what is a behavior problem? If I want to know, I've got to ask 4 questions. Does the behavior interfere with development and learning? Is the behavior disruptive to the family, school, or workplace? And I'll go back in when I said learning. Learning means, it's not that the teacher, he can't learn. What is the teacher teaching him? So if the teacher is teaching the child and he's not learning, so perhaps she should teach him the way he should learn. We should know which learning style is this child with Down syndrome. There are different learning styles, and this can be addressed in another lecture, but you can get children that are visual, usually they are visual, or they just like to feel. So I got to know. So it's not because the teacher doesn't know. And again, if you say disruptive to the family, it depends what the family is doing. Are they taking it to the supermarket and the child is playing up? Are the family embarrassed to take him to places, and that's where the child is paying up, or one mother wants to go elsewhere and the child is preventing her? We really need to take a good history. Is the behavior harmful to the child, adult with Down syndrome, or to others? In this aspect, it is zero tolerance. If the child is harming himself or compromises his safety or other people, this is a zero tolerance. This is not acceptable, and this is a safety issue, and it's very important. Is the behavior different from what might be typically displayed by someone of comparable developmental age? As I showed you in the previous slide, I should not compare it to a 9-year-old. I'm not comparing a typically developing child or with a child with Down syndrome, nor a child with Down syndrome with Down syndrome. The range is the range is quite, it's quite wide. So I really cannot rely on that. So if I now got a problem, I will deal with it. So this is maladaptive behavior and challenging behavior, and they are used, maladaptive behavior and challenging behavior, they are used interchangeably. But what really is what is meant by maladaptive? It is the type of behavior that inhibits a person's ability to adjust to particular situations. It is often used to reduce one's anxiety, but the result is dysfunctional and non-productive. And this is like, for example, if the child has got anxiety from going to a place and you avoid him and you don't take him, you don't let him go to this place, this is counterproductive. You haven't treated the original problem on the long term. And then the child, you will continue to avoid this situation. Challenging behavior is any behavior that interferes with the child learning, developing, and success, is harmful to the child and puts the child at high risk for later social problems or school failure. So sometimes you will be using all these terms interchangeably, but this is the precise meaning. So features which may suggest, as I said, we need to take a good history. Your history, your diagnosis is as good as your history. If you don't take a good history, you're not going to strike it lucky. You're not going to be right, and you'll fail right from the very beginning. So there are some features when I want to deal with a behavior, just to make it, is it just straightforward, or there is something that I need to be more concerned about? So the behavior, if it is acute, if it is new onset, if it is intense, if it is frequent, long duration, if it is prevent the child from learning, yes, I need to have serious consideration. If there is physiological or emotional problems, there is problem with the sleep, there is increased or decreased hyperactivity, there is mood, there is irritability, all these are significant. The neurocognitive symptoms, there is abnormality of the gaze, abnormality of the attention, abnormalities of the cortical organization, the play, the routines, so many symptoms I need to address. And if there is family history of a major family history of psychiatric problem in the first degree relative, like schizophrenia, bipolar, or autism spectrum disorder. Over the next couple of slides, I will just share with you the behavior and what, if it indicates a neuro behavioral disorder, or if it doesn't, what will concern me. So if I'm talking about hyperactivity, which is very common for all children with many children, actually when I say many, it just depends where are you getting your patients. If I am dealing with the children that I see in my clinic, I will say really the majority of them, because this is a specialized clinic, so the children that will come down my way will have some more difficulties. But it is hyperactivity is an area of, is quite common. So if the child is excited or overstimulated, it's okay to be a bit hyperactive. But if it is associated with unsafe or high-risk behavior, that will concerns. What concerns in the hyperactivity is that the wandering off. If the child wanders off, this is a safety issue. So sometimes what we advise the family that in the house, you put before leaving the house, of course the locks, like any other child, the safety, and then you put a stop sign and make it a culture in the say, so everybody before, I'm going out, mama, I'm going out, mama, you know, so everybody knows this is the culture in this particular house. Everybody goes out, must say that he's going out. So then the child will know. You are teaching the child and skills, and this is a good skill. We all need to know where other family members, not like now, everybody just goes and nobody knows where everybody is. So, but this is important for the child to know. Okay, non-compliance or tantrum. Temper tantrums, every child has temper tantrums. If it happens in typically developing children, the temper tantrums usually happen at 2 to 3 years. In children with Down syndrome, it occurs a bit later, 3 to 4 years, and it lasts longer. So if the child will have a tantrum, if you're disciplining, you're putting limits, as we said, a child with Down syndrome should be disciplined like any other child. You want him to have the values, you want him to have the manners, and so if you're putting the limits, or there is a sudden transition, the child was having a good activity and you suddenly pulled him out without warning, without reassuring, without telling him, then it is our fault, not the child's fault. But if this tantrum have got aggression, self-destruction, injury, or destructive, then this is, again, it is concerning. Sometimes if the child will have, he doesn't mean to be aggressive or destructive, but if he throws something and the person is passing by at the wrong moment, and then he will get a chair or get to whatever as at the time, then it is not meant by the child, but again, this is a risk behavior. If this happens in the nursery or school setting, this is difficult. Anxiousness, agitation, and disruptiveness. Again, if the child has got pain, all of us, if you've got pain or physical discomfort, we will be quite irritable. But if, again, self-harming, as I said, is something serious that should be we should come really to the bottom of it. Repetitive behavior, and this is, we see it a lot in children with Down syndrome, and not every child, I'll be talking more about that, not every child that has flapping of the hand or twirling, you will say, yes, he's got autism. If the child, stereotypic movement disorder, if the child is another entity, I will be talking about this in the next few slides. But if the repetitive movements, when the child is tired, but if they're easy to interrupt, you say, come on, let's do something, and let the child do something with you, that is okay. If it is brief duration, or what we call overflow, the child has got so much energy, so he's just flapping his hand or twirling or spinning, that is okay. Okay, we will take him, it's nothing to raise red flags. But if the repetitive movements, they occur across a variety of situations, it becomes a preferred activities. That's what the child is doing all the time, dangling, looking at things or that is not favorable, or if it is difficult to interrupt. You tell him, you try to engage in the play with him, with the child, and you're failing. So this, again, is concerning. Peculiar sensory responding, if there is tactile defensiveness, if there is auditory hypersensitivity, or there is oromotor, and there might be just mild aversion or just some agitation, that is okay. But if you're getting the sensory, they are preventing the child from, like for example in the house, every time the parents are going to clean or put a blender or the TV is high or whatever, and this child will just go really agitated with autonomic symptoms and anxiety, then I need to be cautious about that. A typical neurocognitive processing, using the eye gaze. Again, if there is any vision or hearing problems or with acute medical illness, that would be okay. But if it is the child is not able to play, his eye gaze is not right, so maybe using his peripheral field of vision, or if the child does not understand what you're telling him, mainly understanding. I mean, as I said, talking or expressive language is delayed in children with Down syndrome, but understanding is a better skill. So if the child doesn't really seem to understand, and not only the verbal words, but as well as the gestures. So if you're telling the child come, so the nonverbal that doesn't depend, then I really need to consider more evaluation. This interest in social interaction or play, again with medical illness, emphasis made again, as you have seen repeatedly, about the importance of addressing the medical issues before. And if there is little peer interaction, the child is not able to engage in any symbolic play or organized play activity. And here I'm talking symbolic and pretend play, not just play repetitive, doing this and that, or piling things or arranging things. I'm here very careful, and I'm emphasizing that it is symbolic play and organized play activity. So I will very briefly touch, for the sake of time, about the behavior, how to approach it, consider the emotional stresses at home, school, and work that might impact the behavior. If things are going wrong in the family, if there is a dysfunctional family situation, this definitely will impact upon the child's behavior. We should work with a professional. The parents can really need the advice, and it can be anybody. It can be an educator, it can be a counselor, it can be a doctor, it can be a teacher, anybody. And we use usually the principle of positive behavior support. I'll be showing briefly over the next slide. And we identify the function of the behavior and develop a plan. Every behavior happens for a function. We are going to do some detective work. What is it? What is the function? The first function, I need to make sure that this is not behavior the child is acting up to communicate. It might be the child, he just wants us to acknowledge this is his mean of communication. So instead of patting, we'll come or pull the child's hair. And this is a common occurrence. So in the school, oh, he is pulling other children's hair. Did he pull them intentionally? No, they just want an interaction. So we really need to know, first of all, we need to rule out communication problem. Another function, it can be there. I will mention it here. So for any behavior plans, we've got ABC. Like anything, what happened before the behavior, what triggered it, what did behavior entail, and the consequence, what happened, and what is the hypothesized function. So if the child plays up, and then you give him everything that he had, so he got what he wants. So this is a trigger that has been positively reinforced. Or if the child, you're doing something with him, and he's perceiving it that it is quite challenging, and then you took it, خلاص بلاش دي, let's play with this. So this is okay, let's play with something else. Then you have negatively, you've taken away this reinforcement. So this is negative. So the child will just continue to do that. Okay, so, and then it can be attention seeking as well. This is a positive behavior plan support, but for the sake of time, I will not go into details, but really what is your strategies to address the setting events, antecedent strategies, skill building strategies, and consequence strategy. So this is how you build for a positive behavior support plan. Please, I'm sure nobody does, but we see a lot of this now, no corporal punishment, no physical punishment, no locking, nothing at all. Maybe time out in the right place, but please no punishment or denying children, things unfairly or rewards unfairly. We really need to be very careful. So what is a dual, I will move on now to a dual diagnosis. Dual diagnosis, it's applied to the coexistence of symptoms, both intellectual and mental health problems. In the past, this has only recently been described, and there is the dual clinic now present on its own in the mental health and in the developmental medicine. In the past, there used to be diagnostic shadowing, whereby the presence of intellectual disability is invoked to explain away every type of behavior. Everything is sometimes done due to intellectual disability. And sometimes for the sake of services or unlocking of resources, you've got to put intellectual disability as the primary, because that will, if you say writing a letter for education or social services, then yes, intellectual disability will unlock. You will get something for it, support. But if you say ADHD or oppositional defiant, what? Black. Nobody knows. So you will not get anything. So sometimes by the time, this is the only diagnosis that is left. So I will just mention what is usually seen in children with Down syndrome: the attention deficit hyperactivity disorder, opposition and defiant, and the disruptive. They are all on the same continuum. It is very, very difficult to diagnose, because all the standardized rating scales, it is very difficult, I take back what I said, to say exact figures, because all the research, when you are doing research for children with ADHD or ODD or whatever, they exclude Down syndrome or children with intellectual disabilities are excluded from this. So you really don't have accurate figures. You can still use the standardized, but we are very careful. Like, for example, one that springs to my mind in inattention in ADHD, inability to follow instructions, not due to lack of understanding. So maybe children with Down syndrome, they are not able to understand, they are not able to attend to the activity because they don't understand. The work has not been adapted to the level. So we need to be very careful, but despite that, we have children with Down syndrome that have got ADHD, ODD, disruptive behavior disorder. And ODD, there is something, actually the mothers of children, something called stop, drop, and plop. All of a sudden, you're in the middle of a super aware, and then the child will stop, and he will drop, and he will plop. Yeah. Who will lift him, who will there? That is very difficult, and this is something very common. Obsessive compulsive, it might be simple, just aligning things or dangling, or using the same chair or drinking from the same cup, or it can be quite more complex. Usually we get more the compulsions rather than the obsessions. Obsessions need theory of mind, you need to have a bit of imagination, and sometimes we don't see it as it is in children with and persons with Down syndrome. I will talk a bit about autism spectrum disorder in the next two slides. Stereotypic movement disorder, that's what I said. It is present, you see it in children with Down syndrome more so than in the general population, and it does not mean that the child has got autism. The social relatedness is preserved. If the social is affected, then yes, we've got to do an evaluation for possible autism spectrum disorder. But you can see, we see in the clinic, a child is smiling, looking at your eyes and giving a hug, and he is flapping or twirling, and they say, oh, he's autism. No, he's not. Enough the eye contact and the social interaction and the sharing the child is giving. So we need to be careful. The reason why I'm mentioning autism spectrum disorder in a bit detail, it is becoming something that we are getting, many children are being diagnosed in line with the children with the increase of the autism spectrum disorder. It's around 7% using the recent diagnostic reliable criteria. Compared with children with autism spectrum disorder in general, children with Down syndrome, they are much older because they slip through the net. Sometimes they're not diagnosed as young as 4, but it can go up to 7 and 8 years. They tend to have a more cognitive impairment, and the prognostication, if there is a low IQ, if they are nonverbal, and there is presence of other comorbidities like infantile spasms or uncontrolled seizures, they are important. Sometimes we get as well children that have had post-cardiac complications. They are at high risk of autism spectrum disorder, or if there is a family history of autism. Children with typical Down syndrome are different from children with Down syndrome and autism. They are different from children with autism on their own, and they are different from children with intellectual disabilities. So we have got 4, and they are different, and sometimes it is quite difficult to see which is which. So children with Down syndrome, what is really more, they are better in the social interaction. Yes, they are not as isolated as typical children with autism spectrum disorder. So there is history of developmental regression, and it usually happens at the later age. So children, when they are children with autism, they regress at around 18 months to 2 years. Here it's a bit later. It can go up to from 3 to 7 years. Poor communication skills, many are nonverbal, self-injurious and disruptive behavior, repetitive motor activities, and I have put the examples for people to be aware what is meant by each of these characteristics. Unusual vocalizations, unusual sensory responsiveness, feeding problems, and food refusal. Increased anxiety, irritability. Sometimes after the child will be quiet, parents will give, in case with regression, the parents will give a history of typical development of a child with Down syndrome. He is developing typically like any child with Down syndrome, and then he will regress, and then there will be increased anxiety, irritability. When do we use psychotropic medication? It's a shame, but now we are seeing a lot of children, Down syndrome and not Down syndrome, specifically children with Down syndrome that are being unnecessarily medicated. Medications are there to help, but they should be used in the right place. So if there is the behavior is mild or occasional, if the child is young, if the behavior are limited to specific environment, if there is a medical condition, as has been many times mentioned, if there is psychological, emotional, they are not present, or you haven't tried behavior. You cannot try medication without trying the behavior. At least give it the benefit of the doubt. Okay. On the other hand, as medications are there to use, if their behaviors are rapidly becoming worse in an otherwise stable environment, that means the family, the school, and again, the child is in good medical condition. A major psychiatric orders is present, like ASD or bipolar, or as I mentioned, the child is not progressing well. If there are physiological or emotional changes, if the person did well before on medication, but they were stopped, or if all the behavior has been tried with a good cooperation from the therapist and the child and the family, and it was unsuccessful, then we try medication. I'm using this transition slide to go into adolescence. I finished the preschool, but here, when the children are in school, we think about, this would say, what I need to know and be able to do when I leave school. We have got to prime these adolescents that are entering into a young adulthood life to make the transition easier for them. Unfortunately, many of these young adults get into adolescence and adulthood not prepared. So compared with the children with Down syndrome, the adolescents, they come, as I said initially, the hyperactivity gets lower. There is decline in the externalizing behavior, but there's increase in the internalizing behavior. They become more secretive, they become more socially withdrawn. There are many changes. Transitions because the children, people and doctor, everybody believes that these children will remain children all through. They are not priming them. We are not teaching them skills. And I want to emphasize about the social and the sexual education. They are children. They hit puberty, as we have heard today, at the right time. The hormones are there. The body changes are there. But without the social maturity, which is lagging, without the how to self-control, without how to deal with these situations in a culturally and socially sensitive way. You want 5 minutes? Okay. So with the difficulty with transitions into young adulthood, there is loss of the social networks, awareness of being difficult, rejection, departure of older siblings. So these are the reasons. I will just need to rush for the sake of time. There is sensory deprivation, the hypothyroidism, that's the medical, and development, like we were talking about development in the first slide. Now in the initial slides, there is age-related cognitive decline in the cognitive function and the adaptive function. This is just goes like this. This is the natural progression of Down syndrome, and memory is most prominent here. So the psychiatric disorder, the depression, obsessive compulsive dementia, and Alzheimer, and I will very quickly mention about depression so that it doesn't go slipped. Depression in adolescents and adults with Down syndrome, they are more than the general, than other people with intellectual disabilities, and these are the symptoms: the withdrawal, the mutism, decreased speech, poor concentration, agitation. they're outlined here. What is depression in adolescents are not verbalized. They cannot say preoccupation with death and suicide, feeling of guilt and disappreciation. This differs them from depression elsewhere. It is difficult to differentiate the depression from the dementia, from the Alzheimer. Alzheimer, Down syndrome, Alzheimer, and chromosomes, as has been chromosome 21. It is fascinating. There is high prevalence of Alzheimer disease. Almost all children, they have got the individuals with Down syndrome, they have got the plaques and the tangles and the APP that has been mentioned by, earlier on by Dr. Makter. It is present in all the brains, but not all the children, not everyone develops Alzheimer. Alzheimer happens, it's the early onset one, 20 to 30 years earlier, so it will happen around 40, 50 as compared, and it is because of this APP. And this is the Down syndrome, this is the chromosome 21, and it is fascinating, as you can see. All these disorders happen, I've got genes located on chromosome 21. It's very fascinating. So in summary, the most useful children with Down syndrome, they fare very well in their families, in their families, schools, and communities, and they don't have significant psychiatric or behavioral disorders. Individuals with Down syndrome are vulnerable to psychopathology, yet the rate is lower than with individuals with other causes of intellectual disability. Children with Down syndrome are susceptible to disruptive behavior, aggressiveness, attention problems, and oppositional conduct disorders. As the age advances, externalizing decrease, internalizing and symptoms of depression and withdrawal happen. And the state of the art of trisomy 21 continues to grow, and appreciation of its distinctive cognitive psychopathology will improve the clinical treatment and care throughout the lifespan for individuals of Down syndrome. This is my reference, and I would like you to thank you very much.